One of the things I find most rewarding about working with the CLIC medical students is the one-on-one relationship that I have with them, and the fact that I get to work with them over 6 months' time and really watch them blossom and grow as clinicians. Hi, I'm Susan Bliss. I'm the OBGYN Clerkship Director at the UNC School of Medicine Charlotte campus. A lot of preceptors wonder what would be expected of me as a CLIC preceptor for OBGYN. It's really quite simple. We expect a time commitment which involves a half a day a week for 6 months. The student will be with you in the operating room, in the office primarily, or on labor and delivery. The next expectation is that the student will get direct hands-on experience with your patients and with you. Depending on where the student is in their academic year, it's very important that they do obtain a history independently and discuss it with you. And it's also important that you talk to the student and allow the student to formulate a good differential diagnosis and help pull the plan out of the student instead of telling the student what the plan should be. We also ask that you give regular feedback to the students, and we even have a form to help prompt you to give the feedback if you're unsure what areas to discuss. We have 2 conference calls per semester, at which time you will be giving feedback with other preceptors from other departments regarding your student. Those conference calls last less than half an hour. And lastly, there's a common student assessment form which needs to be filled out twice. It's an electronic form that will be electronically sent to you. We have another video on how to utilize the common student assessment form. Next, we have some feedback from some prior students on what made their clinical experience in OBGYN successful. You ready? You're recording right now?
Alright, this is off the record, right? Someone who's patient, definitely.
I think a good preceptor is transparent, so you know what to expect from them and what they're expecting from you.
Someone who does not make things awkward, and by awkward I mean going in the patient's room and saying, "Is it okay if the medical student comes in?" I mean, it's okay. It's okay if you want to say no. Like it's perfectly fine. You know, I just want you to help us with teaching. You know, like making it a whole big deal. Like all of that is not necessary.
I would say someone who has a clear-cut plan of how you could contribute to the team.
A good teacher.
Someone who loves to teach, loves to answer questions.
Hold you accountable.
If you just go in, give the patient the courtesy of saying, "I have a medical student with me today. Is it okay if he comes in?" It'll be fine. Especially on an OB-GYN rotation, making it awkward makes it 10 times more awkward because, you know, it's intimate. So I think that patients play off of the preceptor in terms of what the medical student can do, what they're qualified to do. And as long as you don't make a big deal of it as a preceptor, then usually it will be fine. So feedback for me occurred every session.
We kind of did feedback at the end of every day or immediately after if it was an encounter doing something for the first time that I hadn't done before.
We only have that preceptor once a week, and we just talk a little bit about how I did that day, what I could do better next time when I see them next week, and how to be a better clinician overall. The first day.
I think I just spent 1, maybe 2 days shadowing.
Immediately. She allowed me to do a lot. So I was able to write notes. I saw patients by myself. I had a lot of autonomy while I was there, as much as a medical student can have.
My preceptor actually encouraged me to learn how to insert an IUD from YouTube. Needless to say, when I came in, I was obviously an expert and I felt great about it.
She expected a lot, but she did it in incremental doses.
And so she gave me time beforehand to review that and grasp my own understanding of it, and then I talked through it with her, and she was there over my shoulders the whole time guiding me. So
She just allowed me to practice every time I went in there by myself, and initially I did it with her, but later by myself, and she became more comfortable with what I found.
I got to do procedures, talk to patients. He would sometimes just have me go in and say, I'll be in later. And so I think just building patient rapport was my favorite part.
I really just enjoyed getting 6 months to meet the patient population, especially in OB. You're seeing women multiple weeks in a row for their prenatal appointments, and so that was really fun to build those relationships.
The amount of procedures I got to do, every time there was a pap smear, IUD insertion, she just let me do it. It was great.
To be excited, to engage your learners,
Just don't make it awkward.
but they can really make or break an entire experience for students, and sway them towards or away from a specific field or specialty.
I know it's easier said than done.
Just allow your student to be as hands-on as possible.
I think that my main piece of advice would be do not assume that a patient is going to be uncomfortable with your medical student. Assume that your medical student is an extension of you and you are directly supervising that medical student, because if you treat it like it's not that big of a deal, then the patient won't think that it's that big of a deal either.
So welcome them.